Hi, good evening. Welcome to this episode of Guts and Glory. And I have with me a dear friend, Dr. Sanjay Nagral. He has taken up the mantle to be the voice of conscience of the medical fraternity. Sanjay, welcome to the podcast. And I look forward to a very introspective session.
Thank you, Sadiq. And this is the first time, perhaps, that I'm going to be discussing it with a colleague, and that partly is a great thing, but it also puts a certain burden because obviously you are part of the same work that I do, and of course our audience also many of them I know. So I'm actually a little
But
nervous. So please.
let me start off. Is surgical practice and ethics, are they at a crossroad or is there a conflict?
I think it's a very, very interesting question to start with. I think we must accept as surgeons that what we do in our day-to-day work, in a sense, violent by cutting open people, we of course now claim to do things minimally invasively, etc. And which is very double-edged because on one hand we have the capacity to heal people, rescue them from life-saving emergencies, but we can actually do a lot of damage. The benefit and harm ratio is there in practice of medicine in general,
Of
but I
course.
think surgery it is sharper. There is also another thing. If you're to be seen to be performing, and everybody around you perceives that you should be constantly, doing dramatic things,
Absolutely.
that also by is
Yes.
a little
Yes.
double-edged.
Yeah.
Uh, but finally, there's one more thing. For us, if things go wrong, actually, there's a huge sense of guilt, and sometimes it's a very private guilt. So yeah, I think surgery lends itself to special challenges.
That you also mentioned that we overestimate the ability to heal and underestimate the potential of harm that we cause by our interventions. So just take me through this, that how you got interested in this, what led you down this path, and how has the journey been?
Yeah, so I think that's again when I look back, that question is important. Partly also because it reflects on how the ethics movement in India took shape. So one of the problems with this whole discussion around ethics is that if it is about, which sounds very moralistic,
Yeah.
it has the potential to to
Sermonize.
go away. Yeah, sermonize. Bioethics is a very big field. It talks about, uh, of course, the doctor-patient relationship and some of the challenges, but it also addresses so many things around us: inequity, discrimination, vulnerability, truth telling, etc. No, one of the things is that, if you are in health, in working in a hospital in India, you don't have to actually be exposed to the theory of all this because you see it every day. You may perceive it in a certain way, you
Yes.
may rationalize it in a certain way, but working in a hospital like that, it was an everyday thing to see. I met people, both around me, but some of my teachers who were already interested in this area. And one of them actually was the ex-head professor of neurosurgery in KEM, Dr. Sunil Pandya, who
Yeah.
incidentally passed away recently.
Yeah.
And I somehow connected with him. And Dr. Pandya, some kind of a role model. I mean, at that time, there were variety of people, senior people around us, but Dr. Pandya particularly was one of those who sort of extremely committed to his patients and to his work, and a very, very different personality. So he was. So I connected with him, and he had always had an interest in ethics. So there was a nucleus of people who connected around him and his work because he started a journal. Originally, a very small little journal which he started. Now, of course, known as the Indian Journal of Medical Ethics, and very well established and perhaps the only one of its kind from South Asia, etc., and indexed. And I was recently told by the editor that they are rejecting about 80% of their submissions, peer reviewed, etc. But when it started, it was like a small publication, and people were just venting some of their feelings, anger, frustration, etc. But interestingly, I met people who gravitated towards this activity, and I met some remarkable individuals, including doctors. And these doctors, I realized, oh, they are also thinking, they are also disturbed, they are also concerned. And so, therefore, I was drawn into this thing. Then I started writing. Initially, of course, very opinionated pieces. But, you know, uh, when I started writing, two, three things happened. One is that I was putting my thoughts down on paper rather than just sort of bottling them up in my mind. Secondly, sometimes when I wrote, people would come back to me and say, "Oh, what you're saying is very true."
Voiced it well.
Uh,
Mm.
yeah, so that of course later on, much later, I started writing in the lay press, and then a column which I ran for a very prominent Mumbai newspaper for almost 2 years, where that was during COVID, and the amount of response I was getting, I would be actually stopped sometimes in my neighborhood or in the hospital, or saying that, oh, you wrote that, and that's a very valid point, etc. So that gives you a feeling that people are responding. And therefore, so that is how I am part of this group.
No, but tell me about the downsides. Was there,
Yeah,
do you
yeah.
feel ostracized at any point with your peers? Was there a conflict?
Obviously, when you write and publicly speak on these issues, inevitably you hurt people. Not necessarily very deliberately, because
Yes.
I generally have avoided personally talking about someone, but certainly when you raise issues. To give an example, I very early on I started writing about the whole issue of, let's say, commissions and cuts, which is uh, which is famously India's, as somebody has written, the open secret of Indian healthcare, right? So I think from behind the scenes also, I was sometimes sidelined, and not very openly, but subtly. And I perceived that in certain situations. But there was something counter happening, and I think that's important to immediately put on the table, which is that a few times people came up to me and said, "Look, we know what you're saying is true. We are sorry we can't openly be with you or your group or your writings." But so there was this parallel thing.
I'm playing the devil's advocate. Writing this would lead to generalization of the whole medical fraternity. And as it is, there is a diminishing trust between patients and doctors. And this will only add to that, that there is mistrust, growing mistrust between that. What would you say to that?
I think it is something that we need to, I mean, we need to address, right? Because the whole relationship between the profession and the patients is based on trust, implicit faith and trust.
Absolutely.
On the other hand, I wonder whether a conspiracy of silence that also prevails, right? Uh, Whether that worsens the situation. Uh, so I'm a little conflicted on this, and I think it's a very valid question, because what we don't want is every honest doctor being questioned and suspected. We certainly don't want that, and there are plenty of honest doctors. Uh, but having said that, I think some of us need to talk
Yes.
about what's going on.
Is ethics absolute? Is there a gray zone?
Question is again very pertinent, and it is not easy to answer. But there are, of course, gray areas. I mean, it would be silly to say that there is some principles cast in stone. But I'm not so sure whether those who say this, that ethics is gray, ethics will differ from person to person, situation to situation, etc. I'm not so sure whether those who say this are saying it from a viewpoint of the need for sharpening this debate, or with a viewpoint which is that therefore let's not get into this at all. So, I'm not so sure. So, if we are qualified and we claim that we have training, and therefore we should be recognized as specialists, trained people, etc., and given a certain status, maybe even a monopoly to practice, then the trade-off is that a society expects us to behave in a certain way. Because after all, when they come to us, they are vulnerable, they are extremely in distress. And therefore, this was the construct of the idea of the ethics principles. It was a contract. And then it got codified into codes and the medical council, etc. So there are some universal values.
Do no harm. I mean, that's
Do
the
no harm. Do no harm if you can't do good. So I think some of these basic
yeah,
principles are universal. Actually, they're in a sense intuitive.
yeah.
Uh, if you put yourself in the patient's place.
So, Sanjay, let's talk a little bit on specifics which we encounter day in and out. And one of the key things, as you said, we are invading the patient and we say we have taken consent. But just to put it in perspective, that A, what is a valid consent? And B, does it have as much legal validity as we believe a consent taken for surgery or any intervention has?
In the real world, I think the question is that basic questions like, have we, as a surgeon, uh, tried to make the person who is undergoing the surgery understand what's going on? Uh, uh, as does that Have we tried to give that person a choice of whether they should undergo the procedure or not? I think these are fundamental questions of a good way to deal with it. Now, when we translate it on paper, right, and that takes a legal form, actually it follows from some of these basic things. How we should be taking consent, because it follows from these fundamental rules of engaging, that
Engagement.
have you understood. Now, of course, what we do in real life, and I am aware that even in my place of work, in my patients, there is a long form, often in a language which the patient does not understand, which is presented to the patient. And often it is some member of the staff who's going there and saying, this is the consent, please sign here. And 95% of our ordinary people who are so nice and who have faith, they have surrendered to us, right? So they sign, right? This is a little different maybe in the private and the public sector, but largely people sign. This is implicit faith. So that is one part, that signing that form. But I think the question for us is that, have we warned the patient enough that they are going in for a procedure, that there are potential problems? So you say, okay, you've got gallbladder stones, symptomatic, you need your gallbladder out, and we'll do it day after tomorrow, and just come and it's a very quick, easy procedure, laparoscopic, no problem. The next day you'll be going home, etc., etc. Now, in that narrative, okay, we know, all of us know. And by the way, I have had two bile duct injuries. All of us who do reasonable numbers likely to have some kind of injury, some kind of bile leak, etc. So we know that that can happen. Now, if that happens, and if you have portrayed the entire procedure as something very simple, very straightforward, very quick, and then when it happens, and you know how wrong things can go, because it's a bile duct injury especially is an example of what can be a very quick, nice operation and what can go terribly wrong. So there is there's a big jump if there's an injury. Also, we have other challenges. In the Indian scenario, especially, things going wrong means a huge cost to the patient. So it's not just the injury and its fallout, but the costs increase. So I think, therefore, in the consent process, we must not exaggerate the sort of the fact that every surgery has some problems, and that it is possible that the recovery can be delayed. So people have asked me, and I think we have actually discussed this in some meetings
Yeah,
also, that
yeah, yeah.
therefore
I
what should
remember
be the
your
consent.
presentation.
So what should be the consent for a standard laparoscopic cholecystectomy? So, I mean, again, don't take my word for it. I'm no expert. Many people do it in their own way. What I've done over the years is I say, look, this is usually a straightforward operation. However, in about 1 or 2% of patients, the recovery can get delayed because you can have unforeseen complications, including bile leak and very rarely injury to the bile duct, which can delay. If it happens, we have the capacity to help you correct it, and but it can lead to potential delays in recovery and further procedures. Now, there are some colleagues of mine who tell me that if you say that, your patients will walk away. But I don't think that happens.
What I was trying to come to is that writing and communicating in a manner, say sometimes you have all these things written in the consent form, maybe not even communicated to the patient, and then you have a official consent form which says we've communicated to this. So maybe if we say that you really need to engage with them to explain and allay their fears of what they are. And if they are concerned about complications, do certainly tell them. If they want to know more, do certainly tell them. But the key thing is to engage with them. And as you rightly said, that sometimes these surgeries, people think that you don't need to spend a lot of time consent in this because it's a standard routine surgery which we are doing day in and out, and that may be the difference between just listing or not listing at all.
So I often tell my trainees that I think the more dangerous operations are the routine operations, right? The
Yes.
smaller ones, the really major ones. Most people,
Everyone is prepared for problem.
etc.
Yeah.
Uh,
So
but there is also one more thing, which is the fact that I think we are in a hurry. Uh, I think it comes from some kind of insecurity. So we are in a hurry to portray a very rosy picture of the surgery, because I think that's where I think the way we practice, where we practice, the pressures of practice, the insecurity of practice comes in.
but let's move on to something after that. And you mentioned that you are sort of protected if you tell them all the complications and all that, and if it happens. But what about disclosure of events which have happened in the operation theater? Is that what you would do in all situations or recommend doing in all situations? Or there is a line that you walk that this need not be communicated to them. It'll unnecessarily worry them that something has happened, whereas it has no consequence in terms of the way the outcome of this patient.
Important, difficult but important question. So, first of all, let me begin by saying that I think if there has been a significant deviation or a complication during the procedure, generally speaking, uh, I think it's a good idea to convey it. Uh, Now, how do you convey it? In what form? How much importance do you give it? Uh, well, that could vary. I think our majority, with exceptions of our people, our patients, are actually quite understanding and tolerant. If they hear it from a second somebody else, right, through the grapevine, or I think it's much worse, especially if you think it's going to impact on recovery costs, etc. I think they're largely looking at your intention. Uh, generally speaking, judging your intentions. Yeah. We have made mistakes like all of us do. But I think if you're candid, if you show that extra effort, extra care, people actually forgive you. Really, what I also do now, this is last decade or so, is that if there is a major deviation, I actually scrub out and inform the family that look, this is happening. I tell them that the surgery is likely to get delayed because of this, but things are under control. We are looking into it, and we will ensure that we will correct it. So that's another. The other thing is, I mean, it just comes that you tell somebody that it's a 2 hour procedure, right? And it goes on to 6 hours. Now, don't take people for granted. You if you are standing outside with your family member being operated, and the 2 hour, I mean, you are missing a heartbeat. So I think a simple thing like scrub out, or somebody scrubs out, goes out and says, "Look, this is it, but we are taking care." I think these are the small acts which
Yeah.
maybe are important.
I don't know whether there would be much differences in opinion. If the major thing happens, you will have to communicate, and it's always a good thing. What I was also thinking about sometimes is, if you're doing a Whipple and there is a bleeding from the portal vein, you've been able to control it. And the thing goes, you expect complications, but when you say there was bleeding and all, then everything is attributed to that, irrespective of whether that's what. So that kind of thing. Or the other part, as you said, is if you have a bile duct injury, I mean, how do you communicate? How do you disclose this?
So, okay, let me first begin by saying that I think I'm a little privileged in the sense I understand that surgeons in India work in very different settings. I have always worked in large institutions. I have worked with teams. I have worked in institutions where I have the backup of whatever ERCP, interventional radiology, blood bank, everything. And therefore, I acknowledge that privilege. Having said that, even if it happens, wherever it happens, I think, first of all, as we said, I think we should communicate.
Of course.
So I think it is okay to say that there was a problem. We fixed it. It is okay to say that I can't fix it. So I have put drains, but I am therefore seeking help. It's okay to say that I need to transfer you to the patient to another hospital. But I think also what people at that stage look for is genuine help and empathy. I know that it is not always easy for the surgeon, therefore, to let's say go with the patient, but at least ensure that the transfer is proper, ensure that all the information is communicated to the next surgeon. Now, there is a one problem which is very tricky in India or in South Asia, which is what do you do with the costs when there is a complication because you have given a budget. And that's, I think, devastating. And I think that rubs salt into the wound. I was once asked, I think maybe you were there in the meeting, that should the surgeon offer to pay
Yeah, yeah.
for the
Online meeting, we were there.
complication? Yeah. Should the surgeon offer to pay for the cost of the complication? Isn't it a acceptance of guilt? Now, that's a peculiar problem of practicing surgery in a country like India. In the sense, in many systems, the patient is not paying, third party is paying, right? What I have done with my own complications is I go to the family and say, look, this is what has happened. Your costs are going to go up. I am waiving my charges. I've been told by people that that's dangerous, but it never has anybody come back to me and said, oh, you waived your charges, therefore you're guilty or something like that. So now whether you should therefore offer to pay on for the further treatment, uh, I think it's not a bad idea to offer some support. Uh, in the right way, because it is rubbing salt into the wound, and I think people generally will appreciate it. But I know
But,
there are counter views on this. Yeah, yeah.
but say you're talking of a complication post cholecystectomy, which is rare, or bile duct injury, if we are addressing that. But there is a pancreatic leak following a Whipple. You've told them, but there's a complication which has occurred. It takes long. I mean, in that way, do we surgeons expect or are expected to sort of show financial this thing towards the patient for a complication which has occurred?
So I think waiving charges, reducing charges, getting people to buy drugs from outside. I mean, that I don't want to go into that territory, but you know that they're cheaper outside. Uh, Getting them, cheaper drugs. I do that all the time, and sometimes I wonder whether it's worth the effort because it's hugely demanding and taxing. You're trying to manage the patient and you're trying to financially also control things. That's because we have walked into a trap of two things. One is practicing in a healthcare system which the funding is out of pocket, largely changing a little, but largely. The second trap that we have faced, you and me, is that we want to do Whipples and we want to do major surgery, and we want to reap the benefits of that, in the sense, we especially, but you're going to pay a price if you're going to do a Whipples. People are, there are going to be complications. So I think that's a trap. This is why how I have negotiated it, but I do not say that everybody can do it. What I
Yeah.
certainly tell my trainees is, please talk to the patient, please spend time with them, please show some solidarity, and majority will recognize that you're trying to help them, and
Yeah.
maybe upset. They may be upset, but they won't maybe not take you to the cleaners.
Yeah, I mean, I don't think that should be the ultimate goal, that whether they are taking you to court or not. But definitely more so when there is a problem or complication, that the rapport and this thing determines how they take the complication. So if you have a good rapport, you have a good explanation, and you are taking them step by step, this is my experience, that they accept all complications. And you can, once you narrate them the course and options, the way it would go, they are thankful for that. And I agree that many times, I think, we do sort of demonize the corporate hospitals, but they are quite generous at times when you request them to sort of waive off charges or uh, give substantial concessions if you deem it necessary for that patient. So it works, it does work. It's just a little more effort you have to put into. Sanjay, let me take you somewhere else now. Uh, Now we are sort of in an era which we can call it as era of innovation, and people embark on doing procedures which are a novelty, which are not established, which are not the standard of care, but they offer them to the patient as a new modality, upcoming, the best thing, next best thing which is going to happen, and so on and so forth. What do you advise youngsters if they want to do an innovative procedure or something which is not a standard of care and they want to do it? How should they go about doing it?
I think you need to at least get your peers involved and say, this is what we want to do. I think we have a challenge because there's nobody to stop us. In most countries, somebody will stop you, right? Either your head of department or your peer or the institution say, what are you doing? Is this really standard? Here, there's
Standard credentialing and privileging, which is lacking in our. Uh,
absolutely, no, no, it's on there on paper, but
yeah, yeah,
reality is
yeah.
lacking. And
For
therefore,
PPH, yeah.
you can claim anything and get away with it. So no, there's nobody to stop us, which is a big problem. Is that when I said there is nobody to stop you, actually it's the opposite. This kind of thing actually is rewarded in our setting, where you do something flash in the pan, and you can be in the papers, and people will suddenly applaud you as if you've done something path breaking. So you can get very heady on that. And I think now the time has come to say, okay, something new. Is it tested? Is there evidence? Maybe build some kind of consensus in at least in your department, and maybe tell the patient that, look, this is something new. There is support for it, and we are going to do it.
So
Right?
I generally would tell people that if you want to do a new or a untried procedure, then the best, as you said, the first step, your department, you need to have a discussion so everybody is on board. And I think you should write to the hospital that this procedure I'm going to embark on, this is my experience or whatever based on that, because then at least they are in the know-how, and if they grant you permission to do, at least you know that there is a process which you have gone through before you undertake that, rather than just going and doing it.
Yeah, and Sadiq, that brings me to a point, which is that actually in India now, of course, all hospitals have ethics committees, right?
Yes,
But there is a small problem there, which is that ethics committees in India currently are mainly meant for research because there are trials going
yes,
on and there are
yes,
global and national guidelines. Fair enough, that is also needed, ICMR. But we actually need clinical ethics committees.
I agree with you.
Yeah, where
Absolutely.
who can guide you on, can you do this? Uh, uh,
Should you
also,
do this?
yeah, or also in the whole area of withdrawal of life-sustaining
Yes,
treatment, etc. We need ethics committees because I think a validation from a third, because after all, you have a conflict of interest when you do an innovative procedure. Okay, it may be the brilliant procedure, but clearly you are going to benefit from it. So a third party needs to examine it, and I think there is something here, which is that I think where is this self restraint and the self regulation? Where is the collective attempt at looking at whether this is the right way to go? Is an interesting contradiction. We say that we are very advanced as a healthcare system. We offer the world's on par global level world class healthcare. Uh,
yes,
we all say that, right?
yes,
Especially, but world class healthcare also means all this, no? That you try to see what is based on science. Even areas like MDT, that is also world class healthcare, right? So
yes.
that's where there is a discordance that our idea of a world class healthcare is, the slogan which marketing slogan.
Technically and all that, we are there, but I think beyond that, it's. Uh, Let me take you something to the current thing, and it bothers me a lot. I don't know how to respond to it. Uh, Two things. One is proxy consultations, that somebody comes with a whole sheaf of reports and records without the patient who's somewhere else, and they want an opinion.
Right.
And the second is WhatsApp or online opinions required for various problems, either related to some your patient who has been recently either operated or not, or whom you have operated several years ago and now they want an opinion on WhatsApp. How do you deal with it, or how do you suggest people should deal with it?
So if somebody comes and says that we want a second opinion, the patient is not here, but we will come to you with the papers. I do it. I mean, I don't see anything fundamentally wrong in giving an opinion based on the discussion on papers and the family. Uh, yes, I sometimes do tell them that I need to examine the patient. I sometimes do tell them that when we take the decision, the patient must be there because, after all, the patient needs to know what is going to be done. But yes, I do it. Uh, the second part, which is online consultations, right?
Let me just put in my what I feel, or I generally tell them is that I'm not going to treat papers. I
Okay.
need to see the patient, because same information in a patient, my decision may be different, and in another patient, my decision may be different. So, and especially if the patient is admitted somewhere to give an opinion which is contradictory to what treatment is going on, I generally tell them that, the people on the spot are the best judge. I can't give another opinion. and because they are seeing the patient and I have not been following up the patient. So that has been generally my this thing. Of course, I do see a lot of these proxy consults in my practice, but generally for a critical thing, this is my stand. I mean, I
So I
don't know.
mean, there are various ways of these proxy concerns. Sometimes the patient is in the hospital and the local doctor is willing to discuss with you. So that is
Yeah,
one way.
yeah.
But yes, sometimes it is that they have just moved out with the papers. They're not happy with the treatment and they come to you. I don't know quite how always to respond, but I must confess that yes, I do that consultation. I generally say that look, there are some limitations to what I'm doing. Uh, but I will turn it around for you, which is that why doesn't the patient and the family have a right to seek a consultation? Sometimes it's very difficult to get the patient. I mean, it is obviously if they're just going around with papers to 10 people, that also happens. But sometimes it's difficult to get the patient. And sometimes they're very, I mean, I think that some of the challenges of India where people have to travel long distances and there is a family member, in your case in Bangalore, who says, look, I have the papers, I will get the patient, but can I do a preliminary discussion with you? I don't see that as something fundamentally wrong,
No,
considering.
it's
Uh,
not wrong. I don't think it's what uh, sometimes I just feel a bit of hesitation in contradicting an opinion of a, say, patient admitted acute pancreatitis, admitted in a hospital, ICU, day 14, and they come and ask what is to be done. And that's where, you give a contradictory opinion, patient can't come here, and then there is a conflict now amongst the treating doctors and this based on your opinion, which you may change that opinion when you see the patient. So just that. But
yeah.
let's go on. Let's say the second point which you wanted to address, the
So that
WhatsApp.
was on, you're talking
Uh,
about specifically
oh,
WhatsApp or online consultation.
online or
So because
WhatsApp. Somebody sends you a message on WhatsApp at 10 p.m. that my father is having pain in the abdomen and he's not past stools.
right. So there is a wide spectrum, right?
Yes,
One
yes.
is these kind of WhatsApp messages, right? And the second is a formal way of getting.
Formal online. Yes, yes.
By the way, I think it was one of the sort of slightly positive fallouts of COVID that we realized that one can do a lot,
Online. Yes.
and that you can really help people to stop traveling, especially follow-ups, and I do a lot of my
Right.
follow-up consultation now
Yes.
online. But just to come to your other WhatsApp thing, well, yeah, you're right. I think that's becoming a free for all in that sense. People have no etiquette. At least you're getting a message. People call also at
Yes.
10 p.m., right?
Yes.
There is one way to look at it, which is that I think part of the problem is that we don't have an organized healthcare system, right? So it's not as if everybody knows that, okay, problem one, your local hospital or local GP, that GP will refer there. There is no
There's
proper.
no organized system.
So they know you from some other patient. They know that you have done a good job. So, okay, so why not contact Dr. Sikora and say that because somebody is having pain and he treated my brother. So I look at it. Sometimes it's very irritating, but I look at it a little sympathetically that here's a person. So sometimes I respond. I say, please go to the local doctor. Uh, because we have a chaotic system, and we are actually therefore victims partly of this. And by the way, Sadiq, how do they have your mobile number? So we give our cell phone number. So
Yeah.
you
I
know,
mean,
uh, so I think these are all the peculiar challenges that we face of practice in South Asia. I must immediately add though, because we've discussed a lot of challenges, and some of these things are worrying. But I think uh, Dr. Nandi wrote about this a few years ago somewhere, and I completely concur with him. And I increasingly feel now that I'm sort of a little later part of my career that I think we also have uh, the certain privileges of working here, in the sense that, first of all, I think our patients, large majority, have such tremendous faith in you, tremendous, actually inherent trust. We worry in trust, but they have trust and faith. Uh, and they give you back so much. The gratitude is just, I mean, a lot. This is
Finally, I want to ask you, Sanjay, this thing, and it's a very practical thing. I mean, it's not, idealistic world or something like that, but in this time and age, and the way our social fabric, our medical structure is designed, and the way we are working, uh, a large majority in a private healthcare setup, and of course, a significant number in the public healthcare. What are the one, two, three things which you would say which one should do as individuals, as society, as professional bodies of which we are part of, to ensure that we do not deviate, or at least we continue to be engaged in ethical practice of medicine?
Oh, that's quite a question, and that's really a
What
very,
I
very.
mean is, something which
No,
is
no.
doable
Yeah.
and
Okay.
everyone can adopt it uh,
No, I mean,
quickly.
I said it some time back that, I am no one to sort of lay down certain sort of edicts, or, I don't want to sound like that also. So I think we should be a little realistic that we are people who have taken some training, which means we have some responsibility. I sometimes remind myself that there are people who are lying on the operation table in front of you and saying, open my abdomen and do something. I mean, they're surrendering to you, they're giving you that privilege. So I think we should periodically remind ourselves that, look, therefore, we need to have a sense of proportion, sense of responsibility, some solidarity, etc. So I think that's how I would put it. That professionalism means that we understand both the pluses, the limitations, and our collective responsibility. That's actually professionalism. So ethics is increasingly being seen as professionalism in the context of professionalism. Please think of working in a place where people need you. Because big cities, I work in a big city, I work in a very urban, but I'm saying this that the level of competition, it's not just cutthroat, but it's getting to huge proportion with abnormal, bizarre proportions. So that's one. So preferably work in places where people need you, because if people need you, you don't have to do all this. You don't have to sort of pluck out gallbladders, whoever is coming with an ultrasound, etc. So that's, I think, one, if possible, work where people need you. I think the second thing is that maybe, and that's one advice I give, practical advice, try not to invest too much in your profession in terms of, actually spending money. Because that model of putting in money, it's a huge conflict of interest, creating your own hospital. I am amazed what courage people have. And, so people invest their own, because that's a trap. That's a trap. And it may make you very big and famous, etc., and your name may be, but it can be a terrible day-to-day trap. It's best to have limited investment in your work, so that you're not on a treadmill. uh, I think the third, this is something I'll probably end with, is that I think there's much more to surgery than just the act of surgery. Something which is, I think, lacking significantly in what we in the way area we work in the part of the world we work, which is that actually there are many components to surgical practice. Right, there is research of some sorts. And research doesn't mean that you have to do the level one randomized control trial, not at all, but even a good audit and presenting your work. The second is collective discussion. It's very important. Don't be lonely in your work. because you need people to tell you, no, no, you this is best not to do. So you should have sounding boards around you, work together. Yeah. And the third, I think, you know, be involved in teaching, partly because it's a good thing to do, but also because it's only when you teach that you have to also read. I mean,
And
sometimes,
you
yeah,
will learn when you teach.
yeah, yeah, yeah.
Yes.
But we should increasingly discuss this. I
Yes.
think there should be forums for discussing, the collective discussion. Uh, Whether it is ISG, I think we should discuss some of the challenges we face. Something somebody says somewhere, you get a good idea or some good practice. Also, it's very important to know that others are going through the same challenges and that you are not alone and they have found a way out. And this is also some of the things that I told you how I got involved with these groups, and because I realized that people are more equal there, they discuss, they respect each other, etc. So
And I understand that with this recent this thing of end of life care and DNR, it is mandatory to have a in-hospital clinical ethics committee.
yeah,
Uh,
so the recent Supreme Court judgment, in a series of judgments on the starting with Aruna Shanbhag case, but so the common cause case. So basically, it says that yes, you need to create a primary board and a secondary board. It has its own challenges, because what should be actually a decision of a group of doctors in a hospital with the family, shared decision making, has now connotations which are legal, which is sometimes complicates it. But increasingly, there is a recognition, even from the highest court of the land, that we are not people who can do miracles. There will be lots of uh,
yes.
individuals in ICUs who are getting futile care, and that we need. People are watching us, and why should they not? We have a claim to, be specially. So I think we should therefore come out in the open, be transparent, say this is what we collectively believe in, this is what we do, this is how we discuss, we take consent. If we are going wrong somewhere, please tell us. We'll collectively change. Something like that. So
Yeah, thanks a lot, Sanjay. It's a lot which we have gone through and discussed. And I mean, it's always a pleasure talking to you. And we may not get answers to everything, but at least it is food for thought and it just stimulates how we ought to be thinking towards our patient care in a right manner, which could be also termed as an ethical manner.
yeah, yeah. So once
Thank
again,
you.
thank you very much, Sadiq. And as I said right at the start, it's very rare for me to be in a discussion with a colleague on these issues for a podcast. I really consider myself privileged, and I hope that you continue your journey of podcasts, do more and more. You can bring in lots of people, and I'm sure a lot of people are now looking forward to your podcast. So thank you for the opportunity.